So, good evening, everyone. So, this is the last session. So, without taking much time, I promise you that I am here only for 15 minutes with no heavy words, no heavy terminologies, no clinical trial, no research paper, and no monoclonal antibodies, nothing else. So, before I start my lecture, I would like to congratulate Dr. Manoj Toshniwal for achieving a first milestone of his career and wish him many more to you. Thank you very much, IMA Aurangabad and entire Jeevan Amrut team for giving me this opportunity to be here. So today's my topic is very simple, a role of pediatrician. I don't know how many pediatricians are there except my three chairpersons who are senior to me. But let it be, though it is a pediatrician and if physicians are there, the base is same. The concepts are the same, only the age group differs. So let me just quickly start. So before start, I acknowledge my teachers, colleagues, and friends because of whom today I am here. So when we have a cancer in child, when we say the first of all, many reactions we face. Whether is it possible? या डॉक्टरांना समजत नाही, चुकीचं निदान आहे, कुठेतरी दुसरीकडे जाऊ, and many more. Many of them, they just broke down. They are full of tears. They just take opinions, whatnot. But yes, let me tell you, the journey of cancer, journey of patients suffering from cancer, and journey of doctors treating the cancer is very much remarkable, and it is started with this. So this was some 50s, 60s, 70s, and when the cancer was the end word. So there are no hopes, no life. Cancer means everything is over. But of course, science is advancing, technologies are improving, and what we see here is something this. So yes, cancers are curable. But we didn't stop here because, we want something more. Dil mangta hai kuch more and kuch ho jaye some more. So again, we further moved, and this is what we are here, and we are here to inaugurate this transplant unit. So it is not only non-curable to curable, and ahead that yes, it is transplantable. Okay, so epidemiology cancer, since morning we are hearing this word, so I won't go in much detail. Yes, worldwide below 15 years of age, almost 90,000 children are suffering from cancer per year. In India, the incidence is 0.5 to 5.8%, but increased incidence is an emerging concern. Yes, because of the increased awareness, new modalities, the more sophisticated diagnostic imaging, and all the facilities which is available now everywhere, even in interiors. But because rather than an increased incidence, I will say gender bias is still an emerging concern, especially in India. If we get a female patient with cancer, 80% chances that the child will die at home. Okay, so that is still there. And out of all cancers, yes, in pediatrics, leukemias are more common, 25 to 40%. Out of that, blood cancers are most common, followed by the CNS tumor. So role of pediatrician or a general physician, yes, what can I do? Yes, your role is the most important, and you can do what even a super specialist can't do. How? Let's see it. Okay, so pre-therapy, suspicion, early diagnosis, and early referral to the proper center. That is the key to treat the cancer. So this is the case first. This is a 4-year female child born of non-consanguineous marriage, history of fever since 5 days, history of pain in joint since 1 week, history of rash, past history, family history not significant on examination, child is sick looking, vital stable, pallor present, cervical lymphadenopathy, joint stiffness, per abdomen organomegaly is there. Now, since we are in a hematology conference, so without wasting the time, we would like to go ahead with the investigations, and this is the CBC with pancytopenia, hemoglobin of 6, TLC is 2000, but we don't rely on TLC and we go for ANC, that is absolute neutrophil count, which is just 10%, that means 200, which is very, very severe neutropenia. Then lymphocyte is 85%, platelet are just 6000, peripheral smear, pathologist reported few atypical lymphocytes and platelets were reduced. But When this PS was reviewed by him again, this is what we saw. And we had a differentials, whether it is SOGIA, that is systemic onset juvenile idiopathic arthritis, or LRM, that is lymphoreticular malignancy. But the PS, which is a simple bedside investigation, has given us a diagnosis. So what next? Yes, we will admit the child. Further investigations needed. The most important is serum biochemistry, that is renal function test, serum electrolyte, uric acid, LDH, calcium, phosphorus, that is tumor lysis profile marker, and chest X-ray. Chest X-ray to rule out any mediastinal mass. IV fluid hydration need to be started as soon as patient is getting admitted without potassium chloride. So this is the must, that no KCl to be given in any pancytopenia patient unless it is indicated. Okay, so we have three things. We will transfuse because patient is anemic. We will transfuse platelets because patient has thrombocytopenia. We will give steroid because joint pain is there and one of our DD is SOGIA. And whether we should do a bone marrow for diagnosing the cause of thrombocytopenia. So let's see. So specific treatment, steroid, one dose, single dose, at least till we are referring the patient. So no empirical steroid in any case, come what may, because it will mask the picture. Even a single dose of steroid will put patient into the temporary remission, and the disease we won't be able to diagnose. Delaying diagnosis, steroid are immunosuppressant, it will cause severe infection, and whenever disease will come back, it will be more resistant and will prone for relapse even after the complete treatment. So no steroid empirically. Now transfusions. So don't transfuse unless patient is having severe anemia, patient is decompensated in failure, or active bleeding is there, because it is easy to send a patient than to give a transfusion. And as said earlier, that no transfusion is the best transfusion. Bone marrow, now let's, PS has given us a diagnosis. So in periphery, don't do bone marrow just to diagnose a leukemia, because it won't serve any meaning. Because for treating, we need flow cytometry, cytogenetics, and karyotype to subtype our leukemias. So somebody will ask, is it okay if we do bone marrow and send the marrow sample in EDT and heparin tube with the patient? I will say, don't do this, because blast degenerate within 24 hours. They are temperature sensitive or heat sensitive. So it's better to refer the patient. So this is what earlier someone said, that we should know what to treat and what not to treat. So these are the things, what to do, what not to do. So don't do anything, just counsel the patient. The role is very important, to counsel, to give a positive hope and send patient to a proper center. Case 2, this is 8-year male, come with history of cough since 1 month, history of fever since 15 days, history of breathing difficulty since 7 days. Child was admitted outside, received antibiotics, and pleural tap was done twice, but it was refilling again and again. So this was the chest X-ray, and if you can see a big mediastinal mass with the pleural effusion. On examination, child was apprehensive, respiratory distress was present, and distress used to increase on supine position. Pallor was there, organomegaly, and air entry was decreased on right side. So this is the emergency. So as a physician, as a pediatrician, we should know what to identify as an emergency. This is a large mediastinal mass with respiratory distress. So no need to hurry in investigating the patient. First, stabilization is most important. Counsel the patient, make him relax. Don't make him apprehensive more. Already he is apprehensive. No supine position, because distress is increasing in supine position. Counsel patient, make him comfortable, put IV line in lower extremity. This is very important because there is a large mediastinal mass, to collect the blood for investigation. His CBC showed hemoglobin 9, total counts are 1 lakh. So he is in hyperleukocytosis with neutrophils are just 10%, that is 10,000. This is what hyperleukocytosis. If we see PS, it is full of blast. Now the blood biochemistry showing that patient is clear cut in tumor lysis syndrome, because high potassium, high LDH, high uric acid, low calcium, and high phosphorus. So this is a large mediastinal mass with hyperleukocytosis with tumor lysis syndrome. So what is the role of physician or pediatrician? Admit the child in PICU under continuous monitoring. Hydration 2 to 3 liter per meter square without potassium. Monitor CBC and TL profile every 4 to 6 hours. If bleeding, then only give platelet transfusion, but it's a hyperleukocytosis. Please don't transfuse PCV. Can do pleural tap. Send pleural fluid for cytology. This is the easiest way to diagnose the leukemia because the blast cells are present in that pleural fluid. Allopurinol start with 100 mg per meter square per day dose and Gelusil. Monitor urine output for more than, it should be more than 1 ml per kg per hour. No anesthesia for any procedure to be given. If at all want to give a local anesthesia. Just counsel patient, relax patient, do least invasive things with such patient, and earliest referral with accompanying medical person. This is what is important. Last case, this is 6-year female child, first by order of birth, fever since 5 months daily, neck swelling on left side since 6 months, cough, weight loss and loss of appetite. Now this child has received multiple short courses of antibiotics, paramedical treatment taken outside in interiors for 2 months, and the course of AKT 4 months. Now, when we saw the file, we just got only prescriptions of different drugs. No investigations, no CBC, no biopsy, and no TB workup. And when we did this lymph node biopsy, this is the classical Hodgkin's lymphoma. So this is the same child post 2 cycles of chemotherapy. So that is why proper investigations are important. So so what are do's and don't in pediatric cancer? So first, do's: stabilize patient, counsel parents and patients, basic investigations and proper referral. Giving positive hope is very important. Don't: no steroid, no blood transfusion, no bone marrow, no AKT to be done in interior where facilities are not available to diagnose leukemia and to treat leukemia. And no loose talk with the parents. Ki, "Arey, kai cancer hai, jao de ata ghari basa." Please don't do all those things. Warning signs of cancer best demonstrated by pneumonic children: continued unexplained weight loss, headache with vomiting, increased swelling or pain in joint and limping, lump in abdomen, neck or elsewhere, development of white appearance of pupil or visual problem, recurrent fever not caused by infection, excessive bruising, noticeable paleness or tiredness. So if you see all these symptoms, we just get, because hardly there are 10 or 12 pediatric onco cases, like types of the tumor we need to deal. Not like adult oncologist or hematologist, they have multiple types of cancer. So these are the consolidated, the specific symptoms which should arise a early suspicion. The next important role: managed care between local pediatrician and local oncologist, follow-up during chemotherapy and follow-up of lost to follow-up patients, and counseling family members. Again and again, I'm telling, pediatric cancers are treatable. So please refer them, not to do any loose talk, and giving the parents and patients that positive hope. Yes, it is treatable. Supportive care, nutritional care, treatment of anorexia, nausea, vomiting, antibiotic support during chemotherapy if patient is having febrile neutropenia, blood product support like PCV transfusions or platelet transfusions if there are anemia or thrombocytopenia due to chemotherapy, long line care like pick port care, dressings, collection of blood, giving hematopoietic growth factors, like these are the subcutaneous injection GCSF for which patient cannot every day travel to the bigger centers. So at local level, you can give. No vaccinations to be done during any chemotherapy cycle. That is very important. And the most important is the management of pain, counseling and support to the family. Palliative care role is paramount in providing dignity in dying for the child and supportive family. Our main motto that no child should die in pain. In fact, no person should die in pain, I would say. Any symptomatic treatment in palliative care, like if there is a respiratory distress, you can just give nebulization, oxygen. If there is abdominal distension, can do a therapeutic tapping, treatment of diarrhea or constipation, and convulsion treatment, and again a pain management or the end of life care. The post therapy, I'm proud to say that pediatric oncology is one of the success story in medical science. So early follow-up is very important, and it is been kept by you, local pediatrician, family physicians. Look for relapse, doing periodic CBCs in case of leukemia, physical examination, and early diagnosis of relapse or recurrence can be made. Once patient completes chemotherapy, then vaccinations to be done, that can be done. Monitoring late side effects of chemotherapy like growth monitoring, cardiac function monitoring, endocrine monitoring, behavioral and cognitive assessment, psychological counseling, encouraging lifestyle like diet, exercise, avoidance of smoking and alcohol, and also the rehabilitation. So lastly, take home message: role of pediatrician or physician is most important in childhood cancer. Early identification is must, early referral, stabilization, avoid transfusion if possible, avoid use of steroid, parents counseling, and please, please, please give them positive hope, because pediatric cancers are curable. And let me share, these are few success stories, and I'm proud to share with you that these cute smiles with you, these are my angels and source of my inspiration, because it's not me or you, but it's we who makes difference. With this, thank you very much.
I congratulate Shraddha madam for such a nice talk, and special mention for Manoj sir also for making this grand CME. One question for Shraddha madam regarding as a tertiary care referral center, we get lot of patients with pancytopenia and basically having an anemia of HB of 3, 4. And I could see in your slides at 3, 4 position you said ki avoid transfusion, avoid transfusion. But what happens by the time child reaches to us, if he is started, he is in a decompensatory stage, like a compensatory stage. By the time he reaches to us, he is in a decompensatory stage.
Yeah.
So like we say, ki take a 3 samples, EDTA plane,
Yeah.
transfuse, stabilize, and then shift.
Yes, right.
Will that do?
Yes, definitely. Transfuse only if child is decompensated.
Yeah, yeah.
If it is a compensated anemia, child can wait till he comes to you. In case if it is an emergency to transfuse and we cannot wait, sometimes it happens that it's a night time, we don't know when patient is getting deteriorated. Sometimes parents pressure is there. That time, as you said rightly, that collect some EDTA and plain and heparin tubes, then transfuse. In this case also, when you should transfuse, that don't take out the blood prior and then order for a blood bag, because issuing blood bag will take almost 2 hours, 3 hours.
Right.
So that time you just take a small amount of blood for cross match, get a cross match done. When your blood bag is available bedside to your patient, before attaching blood bag, you just take out the samples for investigation, then attach the blood bag. This is how you can do it. So as far as possible, you should avoid. But as sir, you rightly said, most of the time patient reaches to us, even for not oncology, but even of any hemoglobinopathy or anemia under evaluation, he's already been transfused. So what happens during transfusions, generally there is still practice of giving hydrocort, like pre-transfusion hydrocort, post-transfusion hydrocort, though it is not recommended, but still some people give, and even a single shot of steroid can put patient into the remission. That's why we ask not to transfuse or avoid transfusion as far as possible.
Like take home message will be, you can transfuse if child is in a very bad state. Never use a steroid.
Yes, yes, exactly.
Thank you so much, Dr. Shraddha, for such a energetic talk. Morning, many people were online and even crowd was full. Though all were tired for full day CME, but still your talk was so energetic that everyone was so attentive to your talk, and it really gave such a nice message to everyone that yes, what needs to be done as a doctor from me, what is expected, that is what you emphasize. Thank you so much.